This is a brief overview of how things are different between Uni and HTO when you think of return to sports and return to various levels of activity as such. So we know that both osteotomies and unis work. So if done properly, both are brilliant surgeries with excellent results. But comparing uni and HTO in terms of recovery and function is like comparing Malus pumila and Citrus sinensis. That's apples and oranges. So you should be looking at, you should not be looking to compare these two things, because one is a fracture, one is a replacement of the whole compartment. So one is grade 2 to 3 arthritis generally, one is grade 4 arthritis in uni. The alignment that you get post uni and HTO is completely opposite. You want to push the knee in valgus for HTO, you want the knee to remain in varus or maybe neutral in a uni. Plus the pre-op factors matter as well. So traditionally, when I was being trained, I was told that any person who has a extra demand from the knee, someone who wants to run, jump, dance, do heavy labor, farmers are ideally suited for HTO and not for a uni or a joint replacement as such. Again, traditionally, younger, fitter patients with lower grade of arthritis were chosen for HTO as compared to uni. And of course, they were severely deformed to require HTO rather than a uni as such. We will not talk too much about HTO done in young patients for non-arthritic reasons. So for someone who has a osteochondritis dissecans or a cartilage defect or a meniscal repair or a ligament reconstruction, you want to protect that, and that's why you're doing osteotomy. They are always going to get a brilliant recovery because they don't have significant arthritis to begin with, and they have got a really good functioning knee anyway. So they will return back to normal. We always think of the Tegner activity level scale, and if you look at it carefully, you're looking at level 5 and level 6 when you start talking about jogging on uneven ground twice or 5 times a week. Now, I think Indian roads can be called as uneven grounds and not a flat ground as such. So we're talking of grade 5 and grade 6 kind of recovery. I don't think we are looking at grade 7, 8, 9, 10 in terms of recovery for any patient post uni or HTO. So what I'm trying to say is I'm not expecting our patients to go back to competitive football, basketball, gymnastic, wrestling and ice hockey. We are not looking at that just now. So please remember that. Once again, to raise the same point again, the old diktat that HTO is done for younger, fitter patients with very active lifestyle compared to uni is gone now. So we don't believe that anymore. I normally feel a uni should only be done for a grade 4 arthritis, but recent suggestions from Oxford group is that even for someone with grade 3 arthritis and a root tear of medial meniscus, you can do a uni, slightly beyond me. But I think that's something which is slightly stretched. Again, there are a subset of patients where HTO is done as a salvage procedure. For someone with a really bad medial compartment arthritis, the image that you see on the left, that's a 62-year-old gentleman who did not want a knee replacement at any cost, did a TCVO for him about 7 years back and is still functioning well. Their expectations are very less. They don't want to think about sports. They want to do the normal activities of daily living comfortably. And if they're able to walk around normally and maybe sit cross-legged, they're very happy. A knee in a 54-year-old which is subluxed is not a candidate for a uni, but you can correct the subluxation with a HTO. This is 7-year post-op, and they seem to be doing pretty well post-osteotomy. So we are not considering these patients. So what we're looking at is patients who are similar in terms of their arthritis profile, who have either HTO or a uni and they return to activities or sports as such. Another important factor is the alignment that you get following HTO. When I was being trained, we used to talk a lot about Fujisawa's point, or the so-called Fujisawa's point, talking about 62 to 65% weight-bearing axis correction. And what we find that it's very difficult to return to sports. If you imagine yourself being knock-kneed, it's very difficult to run with knock-knees. So the present diktat of bringing the weight-bearing axis to 53 to 55% works really well. And it's a misconception that HTO fails if it's not brought to 62%. 7 years follow-up of right knee HTO done, stays same, no change. The left side is 9-year follow-up of bilateral stage HTOs, no change in the alignment, works really well. So you need to select your patients comfortably. Another slight variant for those who are from other countries may not realize, but yoga is a big fad in Indian patients, and even if they haven't done anything in their whole life, they want to start doing it after surgery. So sitting in Vajrasana, they haven't managed for years and years, but they want to do that after surgery, after HTO. And for some reason, sitting in Padmasana, Vajrasana and Sukhasana seems to be very easy with a Uni, with a HTO as compared to Uni. People do that with Uni, and in Japan, they do all crazy kind of activities with a Uni or HTO, but in Indian patients are slightly different subset. Another important variation or another difference is the return to activities after HTO and the time frame of activities. So HTO is very slow compared to Uni. Let me just see if I can show this video. Sorry, I always do that. So this is 2 weeks post-op. So he's a 65-year-old gentleman, did a HTO. A clarification, I don't think age is a factor for HTO function. My oldest patient is 74 and is still doing well 5-6 years down the line. So this is the function you expect after 2 weeks. They're able to walk unaided comfortably, and that's all that is expected. As against that, this is a patient 3 or 4 days following a bilateral unicompartment knee replacement. He's of course showing off. He says, I was walking with a walker on what first day, then I was walking without a walker the second day, and then I was able to do everything without it, and I was just carrying the walker essentially. So return to activity is much faster in Uni as compared to HTO. Do you mean that HTOs don't do well in terms of activities at 6 months? At 6 months, you will see patients who are doing this easily without any issues. I'm sorry, this here. So they are able to jump around, they're able to do running and all kinds of activities without any issues as such. A lot of times you treat severe arthritis. This is grade 4 arthritis in a young patient, 53-year-old. Stage bilateral HTOs. Those of you who are keen-eyed will see a Takeuchi type 3 fracture on the right side fixed with a screw lateral to medial, but they get excellent function. But if you look at this gentleman's alignment, I doubt he's ever going to run. So your expectations are different, and your age group is different. Now a similar age group, 52-year-old gentleman, had bilateral unis done 6 months back, and he's raring to go back to sports. You can see his lean, thin muscle mass. You can see the alignment in varus. So he's raring to go. He's went back to jogging, let's say 5 or 6 times in a week, about 7-8 kilometers without any issues as such. On the other end, there are people who have arthritis, and all they expect to do after Uni is sit cross-legged, and they're very happy. This gentleman had his Uni done about 6 years back, and he was very happy to come and show that he's able to still sit cross-legged, and that's all he wanted. So it all depends on the pre-operative activities and the patient demands. Again, one more example, 54-year-old female, just 2 months back I operated on her, and she says, can I start jogging? I'm able to do this, should I start doing that? So except aerobics and Zumba, I feel everything should be allowed for these patients. And the reason I don't say yes for aerobics and Zumba is when you are in hands of a trainer, they try to make sure that whatever the surgeon has done will break for certain. So I generally don't advise doing heavy impact activities. This is a very special gentleman, businessman. A Mercedes with his driver is going in front, and he's running behind it in the morning. And right Uni done 5 years back, runs 10 kilometers routinely. You can see his left knee is not liking that. He doesn't want anything done. He also wanted to start mixed martial arts. I've said no for that. I don't think he'll listen to me ever. That's the only X-ray I have for him, which is about 2 weeks post-op. He never came back for any other X-rays. This is a video he shared with me yesterday saying, this is what I'm able to do. And do you think I need to go for a left one now? I don't know. Let's talk about literature. We all know that we can find literature on any subject, on any direction, with any viewpoint. So this is what I feel are a few sensible papers that I'm going to quote. So if you look at elite athletes, the most of them are able to return to pre-injury status following HTO. But at the same time, there's a paper talking about difficulty in continuing sports activities after a high tibial osteotomy, and 88% of them returned to pre-op level, but only 50% were able to continue beyond 2 years. So what they're saying is patients with good pre-operative knee scores and Tegner did better than someone who did not have that amount of function. Another paper which talks about 67 to 100% plus. So when you say 100% plus return, that means they were not able to do one activity before, but they were able to start that post-surgery. So very positive, even they're able to go back to heavier workload activities as well. What about uni? Uni generally shows very good recovery in most patients, but if you are male, if you are young, if you are low BMI, and if you have a good bone density and high pre-op activity, it's almost a given that you are going to be fantastic in terms of your recovery. So select your battles properly. And funnily enough, this is a paper where I'm slightly surprised to hear that at 10 years, there's no change in survivorship of a uni when compared to someone who's not doing impact activities. So survivorship in a well-motivated patient does not matter. Another paper talking about HTO versus uni. So HTO were generally traditionally more active and remained more active, but the uni patients got the best recovery, so they had the maximum improvement. One quick thing, on the left hand side you see the in details the activities which are allowed for post-op patients, which are allowed with experience, that means if they're already been doing it, and the one on the high side is high impact activities which are not recommended. And the paper on the left side in the ISACOS, Journal of ISACOS, says that all of the patients who were already doing the activities of heavy impact were able to continue. So just to sum up finally, in my understanding and my experience, HTO patients go back to walking in about 8 to 12 weeks. They prefer neutral or minimum valgus alignment. They're able to start jogging at 6 months. They can consider light activities such as non-competitive tennis or doubles badminton and maybe cricket at 9 to 12 months, but it's rare for them to go back to athletics or football as such. Uni patients are way faster in terms of recovery, so they go back in 2 to 3 weeks time. They start 3 months light impact activities, and 6 months they are happy to go back to sports activities. And most important thing, they're very happy that the knee is still in varus, because the patellofemoral joint is very happy as well. So it's very rare for them to have inertial symptoms of going up and down the stairs. To sum it up, if you do a good job, most patients will have the pre-activity level of function. The old dictate that HTO is reserved for more active patients is no longer true. We are doing unis for younger, fitter patients as well. And it's still advisable to avoid heavy impact activities post these surgeries. Thank you.